Good morning, everyone in the room and online. This is our December 2025 meeting of the Community Health Advisory Council. My name is Katie Plum, and I get to serve as CHAC chairperson. The CHAC, or Community Health Advisory Council, is established in Oregon law and instituted locally here in Kirk County. CHAC provides recommendations to the Kirk County Board of Commissioners regarding public health and behavioral health. These meetings are an important opportunity for partners and the community to work collaboratively to support the health and safety of Kirk County. Please note that this is a public meeting, so we are recording, we are taking notes that are public record. However, there is no public comment period, and members of the public may not speak during agenda items. If you are a member of the media or general public and have questions or comment, we ask that you reach out directly to a CHAC member or a staff person outside of this meeting. We'll begin today with member roll call. When you're called, please share your name, role, and organization if applicable. And then after roll, we'll invite staff members to introduce themselves. We're ready to rock? Alrighty. Courtney, you're up first.
Courtney Clarissa, community member and outpatient physical therapist in St. Charles and Prineville.
Excellent. Thanks, Courtney. Katie Plum, I'm here. I'm the Health and Human Services Director for Kirk County. Erica, I do not see. Hope.
Hope Porterfield, mental health therapist and owner at M3 Alliance.
Can folks hear Hope? Oh, I got a nod from Mike. Okay. Way to project.
Cool.
She's at the far end of the table. Okay. April. We do not see Bill. Do not see Kimberly. Liddell. Devin. All right. We are very short on quorum. I feel like we probably should have checked in on people's extended holiday plans. We will not vote on minutes. We'll save those for later. Oh, but first we need to do staff introductions. So let's start in the room. Alex, you want to go first?
Yes, I'm Alex Greenberg. I am a health programs coordinator for Kirk County Health Department.
Thank you.
I'm Shelby Busher and I work for the Kirk County Health and Human Services and the Prevention and Promotion team.
Are we still good on sound, folks? All right, keep projecting.
Hi, I'm Riley Martin. I also work at Cook County Health and Human Services in emergency preparedness.
I'm Stephanie O'Neill. I am the Public Health Modernization Manager. I also supervise prevention, health promotion, and emergency preparedness and response.
Excellent. Look at us go. All right, on our agenda, I was going to sneeze. I'm not going to, at least for now. Can we scroll down on the agenda a little bit? Okay. First up, we're gonna boot the meeting minutes review until our next meeting when we have quorum, and we have a little bit of time for staff announcements to get us started. So Angela, I know you're presenting here in a little bit. Mike or any staff members in the room have anything you would like to share at this point?
I can do a quick share for the high school students. They're doing a campaign to get warm and cozy clothes to people that need them in the community. So if you see boxes around at some of the local businesses with wrapping paper on them, take a look if you have something you want to donate. There's also flyers around with a QR code that'll tell you what stores do that as well, or we can.
Excellent. Anything else? All right. Member announcements. Anything, Hope, you'd like to share, Courtney? I do not believe I have anything. We really are cruising along then. All right, Angela, we're up to your spot in the agenda. So any information you'd like to share with us, you are up.
Great. So on the, I believe Alex attached the draft CFAA narrative that I shared with the group last time.
The
And
big plan.
yeah, the big plan, that was like 30 pages or whatever. So we did get feedback, just like every other county or in Oregon, about things that needed to be added or changed. The interesting thing to me was that I reached out to my counterpart in Jefferson County, as well as the director for DCBH and the director for Hood River, Sherman, and Wasco County, to find out what their feedback from the state was. And we all essentially got almost the exact same feedback. It was 90% the same for everybody, which tells me that they obviously weren't very clear about what they were asking for to begin with, if we all got the same feedback. But I've been working on the revisions. I did submit my revised plan to Melissa yesterday, because we have to have that submitted to the state by the end of the week. It wasn't anything major. It was more of sort of some clarifying questions, projected sort of utilization, that kind of thing. Um, but the meat of sort of like how things are structured, we really didn't get any feedback about anything needing to change in that regard. So I anticipate, well, I hope anyway, that after this next submission, we'll just be able to move forward with getting things signed, because I'm not really sure sort of what that process is going to look like, since this is the first time that it's happened. So that's the update on the CFAA. As far as let's see, what all do we have on here? So that's the work plan update, housing update. So as everybody knows, our sober treatment housing has been open now for quite some time. And I believe we've got 6 or 7 people living in there at the moment. So that's awesome. Our plans for the mental health housing project, which had initially been denied by the city, did go through on our appeal as approved. However, it sounds like there is still a lot of opposition to that project, just in the community in general. And so it sounds as though we are possibly going to be backing out of that project. I'll know more later, but that's what it sounds like. And potentially that could be something that we do down the road, but with a lot more sort of prep and education for the community before sort of moving forward with a project like that. So
Does everyone, oh, sorry, Angela, does everyone here, are you familiar with the project, the mental health housing project? Okay, in the room, yes. Folks online, looks like we're good. Okay. Sorry. Thanks, Angela.
Sure. So it's unfortunate, but we also, recognize that while that is a needed resource, the community also needs to be comfortable with something like that. And so that's probably the route that we will be going, but it's not decided for sure yet. And then inquiring need for a detox center.
Oh, yes, we had a community partner reach out to us. It's not going to be anything that we dig into in depth here today. But I just wanted to share that that has come up in conversation in the community. So maybe it's something that we can revisit in a little more detail later. But are you able to speak to detox resources here in Prineville that we tend to utilize?
Well, I mean, there isn't a detox center in Prineville. Best Care has detox centers in Redmond and Klamath Falls. And we are very shortly going to be it's going to be unfortunate to begin with, but good in the long run. We are going to be expanding our detox, which will require us to actually lower the number of available beds while we're doing that construction. But I can't remember what the numbers are, so I don't want to say something because it's probably going to be wrong. But I do know that we will have to reduce in order to then expand. But that is a project that we're working on right now.
Is that an expansion in Redmond?
That would be, yeah, in Redmond. I don't envision us opening any detox centers in Prineville, because we do have detox in Redmond and also at our Klamath Falls location. So I think any of our clients that we're working with in Prineville, we just send to one of our locations in one of those. And oftentimes it's a recovery mentor who can help somebody get there if the person doesn't have a family member who can get them there.
Is there anything else that you want to share with the group, Angela, in general?
I don't think so. Not that I can think of off the top of my head. I might think of something like when we get to updates or something.
Sure. Yeah, Hope has the question.
The detox center expansion, is it just only detox or will there be a respite care element to that?
No, it's just going to be detox. So when we closed our respite facility, which is extremely unfortunate, I mean, we have felt that, like I think the whole Tri-County area has felt that the absence of the respite. But we ultimately were forced to close it essentially because we were not being paid for the folks that were staying there. And then we were also given a work plan by the state that was so we had a new auditor. I guess they have a new auditor for respites and residentials now. So we had always had the same person. So we don't know if it was just this person not understanding or what. But the work plan that they gave us were things that we absolutely were not willing to change. And so just to give you an example, one of the things on that work plan was your handbook, your client handbook says that if a client brings drugs onto the premises, you will confiscate and destroy the drugs. However, this OAR states that people are entitled to get their belongings back. And so we're like, well, if somebody brings drugs to the respite center, we're not going to give them their drugs back when they're leaving. I mean, that was just one example. There was something similar about like knives. If somebody showed up with knives, you've got to give them their property back. Well, if somebody's there because they are chronically suicidal, we're not going to give them a knife when they're leaving. And so it was I think there were 12 or 16 findings that the majority of them were just, in our opinion, ridiculous. And so between that and the fact that we were not being paid for most of the people who were using the respite, it wasn't viable for us to keep it open. So we will not be opening another one.
Any other questions? Or Mike, do you have anything that you want to share out?
I don't really.
No, okay. Angela, a retirement announcement went out this week. Do you want to speak to that?
Sure. So I think, most of the group either knows Rick Trelevin or at least has heard the name. He has been with Best Care for, I think almost 30 years now. And has been the CEO for the majority of that time, if not that whole time. And we've known that this has been coming but he is retiring at the end of next year. And Melissa Thompson, who was hired earlier this year as our Chief Behavioral Health Officer, has been appointed by the board to be Rick's successor. So Melissa will be the new CEO. They've already kind of been working out a plan for what the sort of slow transition of duties will look like over the course of this next year. Um, and a lot of that will begin to start in the new year. And so I think it's great. I don't know who all does know Melissa, but she's been an amazing asset to this organization. And so I think for her to be able to be Rick's successor, I'm really excited about. So yeah, so that's some pretty big news because Rick's been around for a long time.
Yeah.
Sure is. Okay. Well, thank you, Angela, for sharing all of that. And if you come up with more that you want to share during updates, please do. All right, we are going to shift gears a little bit. The next agenda item for us is it's referred to as the modernization plan. This is specific to local governmental public health. And it's a statutory requirement that we have a comprehensive implementation plan drafted and submitted by the end of this month. So we wanted to give you an overview of where we're at with the plan so far. Public health modernization has been partially funded since, 2016, I believe, was when the state legislature first started allocating state general fund anyway to this work. And so currently, part of the requirements for public health modernization are being at least partially funded. And so we're working on a plan. How do we get to a state of full modernization, which that goal means that all core public health services are available to all Oregonians at the local level, regardless of where they live. So if they live in a large county with metro populations, they would have access to the same services as we would have here in Crook County. Obviously, it would be to scale, but all of those, the goal is that all of those services would be available at the same quality of service level. So I'm going to pass this over to Stephanie. Stephanie's our modernization manager for our local department. And I think really as we provide an overview, if there's something that you would like to speak to or encourage us to prioritize, maybe there's examples of things that you'd like to see, please do maybe make note of that, and then we'll have some time for specific feedback here. And you can always call or email Stephanie or I about this work as well. So with that, it's all you, Steph.
Thank you. Can everyone hear me firstly?
Looks like the mic's picking up well.
Okay, great. So what I attached to the agenda today is the only things that I attached was our table of contents for the plan, and then also the state requirements for the plan. And the reason I did that is because though it is due at the end of the month, the draft is still quite drafty. And so I kind of didn't want to attach that and have people looking through things that definitely need to be edited.
It's also very in the weeds.
In a big way, yes. And it's really in the weeds. And so I kind of didn't want to dig into the entire thing. I just want to give you an overview of what the layout looks like, and then kind of get some feedback. And like Katie said, please don't feel like you have to give feedback today. Anytime within the next like 2 to 3 weeks would be great. A lot of it is wanting to know from our partners, first of all, how would you like to see these programs and capabilities monitored and evaluated by us? Because we know how we do this work, but in order to do it well, we want everyone that are our partners and in the community to be able to tell us, are we doing it the way that you need it done? Also, which of these capabilities want more information about, the way that we do it, if you need help, you know, implementing it throughout your agency or in the community as well, because we do hold a lot with these, and we want to be able to help bring them throughout the community in a really like visible way. I hope that makes sense.
And meaningful.
And meaningful.
So we're
yes.
not just jumping hoops and
Right.
checking boxes.
Exactly. So to show the table of contents, obviously it has an introduction. A plan development and adoption is basically about how we are presenting this to you now and asking for feedback, also through our commissioners and our county admin, and a lot of the ways that we came up with the work that we do. The assessment results are from an equity assessment and some baseline data that we did with our cost and capacity assessments through that we did one in 2016 and one in 2024 that goes through what our capacity has looked like throughout time for these different foundational capabilities and programs. And it kind of measures where we were at, where we are now, and where we are hoping to be. So as far as like how much funding would we need to be at the 100% of that capability, what FTE we would need to be there, and things like that. That is a lot of what's informing this plan, and how we would like to see public health done in Crook County. So the foundational capabilities and programs are part of modernization. The modernization foundation is built on these capabilities and programs. This is what the state expects us from being funded with modernization to be able to accomplish for our community, our partners and such. And like I said, with those cost and capacity assessments, we did our own evaluation of how our department was in 2016, 2024, and then going forward, we are hoping to be able to continue our cost and capacity assessments yearly to kind of bolster that awareness for ourselves. So that being said, I hope you can get a pretty clear view of what these, it's cut off a little bit at the top, but these are the foundational capabilities. And then these ones are the foundational programs. Now there's a lot that goes into each of them. So if anybody has any questions about what each of them are, I would be happy to kind of explain that. Or I can send out some more information about those after the meeting. And then we also have additional activities that in the plan go into other programs like our WIC programs, our maternal child health nurse visiting programs that aren't necessarily funded by modernization dollars, but they're definitely supported by those dollars. And so we go into the same information with those. So I know that was a lot and I kind of blacked out, so I'm not really sure all of what I said. But Katie, would you like to add some to that?
Yeah, well, I think I'll pause quickly to see if anyone has specific clarifying questions that we can speak to. And then I can maybe I'll make an ask and then we'll go from there.
Great.
So are there questions about, so foundational capabilities are what we as a department, we as staff need to have expertise in and capacity to be able to implement. And then those programs are very concrete, structured, programmatic activities that we offer. So are there any questions about any of those, maybe to start with, and what they involve? You did good, that stuff.
I get talking and then it's just like a blank in my mind. I don't know.
I will say that right now, what we are funded to do through state funding that comes to us as part of public health modernization and that legislative requirement, we are a big portion of it goes to communicable disease control, and related to that, the assessment and epidemiology body of work. And I don't know if any of y'all have tried to hire an epidemiologist in Crook County all the time. That's a pretty niche skill set. It's and we don't need a full-time epidemiologist. And so we work together with Deschutes and Jefferson counties, and we all share a full-time epidemiologist that has dedicated time in each of our communities. So we get weekly respiratory reports that come out. They're available to the community to sign up and receive, so you can see what were our flu numbers last week. Is there RSV being treated in our community? What does COVID look like? So those weekly emails are put together by our epidemiologist. And there's also, she helps with disease outbreaks, monitoring if there's a noro pops up, maybe in a long-term care facility. She does the tracking and data analysis on that. We also share communicable disease nurses, because nurses are also very hard to recruit for. And so we have shared capacity that ensures even if our communicable disease staff is on vacation or they themselves out sick, we always have coverage. Again, this comes up probably most often and most acutely in our long-term care settings, to make sure that we have an immediate response if there's ever an outbreak in those spaces, because we need that to be quick and to be able to support those staff in the best way possible, and get treatment to folks who need it. So that communicable disease control piece and assessment and epidemiology is something that we've been implementing over the course of time, really successfully. We have drastically increased our capacity to do that work, thanks to our partnerships with Deschutes and Jefferson counties. And then the other space that we've been investing in regularly, and well, since the very beginning, is the leadership and organizational competencies. Is making sure that our professional organization has the systems in place, the professional development systems in place to make us sustainable long-term to be able to do this work. And I think that that will continue to be ongoing investment. We all know staff turnover, requirements change, laws change. So we will likely need to continue to invest in that space on an ongoing basis. Communications is one that we've bumped up. We subcontract out for a communications specialist. So we have monthly newsletters now. If we need a press release drafted on the spot, it's no longer me that has to do the whole thing. We have someone who can draft and run that. through our channels to approve. Our social media capacity has increased significantly. So if you don't follow us on Facebook and Instagram, please do. Check out our website. We're still working on that, baby. And we're also working on setting up a system to be able to have text message communications with the community, either alerts or just regular, hey, have you thought about this? Maybe based on the time of year, giving out if the air quality is poor, maybe due to prescribed burning, that could be something that we could get to our folks directly through text message in the future. And that's related, the example I just gave is related to the environmental health work that we do. So we have regulatory environmental health work that consists of our restaurant inspections and licensing, testing of pools and saunas and spas. So we do all of that work. Most of that is supported by a fee structure. And so what modernization does is helps us ensure that we have the capacity to do work that's legislatively mandated, that we are monitoring air quality, water quality. We do have funded capacity to monitor public water systems, but not necessarily private. So private wells or really small systems that are, I think there's a cutoff of how many people would have to be on a water system to make it public. So there's a gap there, I think, in our water quality monitoring. There's work that we've been able to do as a result of this funding around a wildfire risk and communications of like how do we mitigate those risks, what maybe air filtration or warming and cooling and air quality resources are available in the community. So for example, the library is one space that functions as a warming and cooling shelter for the public as well as a clean air space. And so a lot of this work we do in partnership with others because we're a small but mighty crew, but we can't do all of this alone. And I think that's where, and one of the foundational capabilities is that partnership development and ensuring that we have strong ties with our fairgrounds, for example, to be able to provide sheltering options, that we're working with our schools on indoor air quality. So I think that will, I know that will continue to be a space that we invest in, is making sure that we're on a regular basis engaging in meaningful ways with our partners. And so that, again, can be maybe if you all have ideas of how we can do that in a more effective way, please give us a shout. We haven't necessarily increased our emergency preparedness and response capacity, partly because that funding is federal, historically has been federal funding, and we've either received flat funding, which is a reduction given inflation and cost of living increases, but we're also anticipating cuts to that, and so modernization can backfill that work. So we've been able to keep that service level steady despite funding cuts in other areas. But that is one benefit of public health modernization funding, is it can backfill for us to ensure that we're able to maintain services.
A little bit.
At least some. Yes. So those are all examples, but I recognize that my goal is that this work looks very specific to Crook County and that we're being responsive directly to needs that may not look the same as they're outlined in statute. We can be flexible and we can advocate for our ability to invest these funds in ways that ensures need is being met here. I think WIC is a good example of that. We're not currently using any state funds to support WIC because we can't, but it is a program that hopefully in the future we can continue advocating for. Not every local public health department across the state offers WIC through public health. They might offer it through other agencies or entities. And so, I mean, it could look like that in Crook County. Right now, it's a known service in public health. And so I think it's, unless that changes drastically, that's something that we want to advocate for maintaining here as a public health program, even though it's not recognized by the state as a core public health function or program. So I guess the ask is, if you've seen a need in any one of these areas based on your work with us or just your work in the community that you would like us to dedicate some more time and effort into, that would be my biggest ask. If we need to add or shift some capacity somewhere, please let us know those things specifically. Yeah, I think
Well, and
really,
also if there's any feedback about the way that we monitor our
Mhm.
progress and measure the impact to the community, I think that's another way that y'all could be really helpful with this. We have definite metrics that we have to hit with modernization and the way that we monitor progress and impact. But if there are ways that you would either like to see the way that we're monitoring that, or a different way that maybe would help your agency to know about, that would be really great feedback as well.
we'll put our epidemiologist to work as if she doesn't have enough to do. But so if we need to create a dashboard or if a monthly newsletter is not cutting it, how else can we get this information to you all? I think that would be the ask. Okay. Any last thoughts, comments, questions? Okay. Send coffee to Stephanie. She is in crunch time. We are presenting this to the Board of Commissioners in a couple weeks at a work session. So if you receive public meeting notices, or if you don't and you want to know about that, you would be welcome to call in or join us for that discussion too.
Yes. Thank you for listening to my TED Talk.
All right, I'm digging back for our agenda.
Oh, sorry, I'm resharing it. Trying to anyway.
Work plan,
Okay.
work plan strategic.
All right, so we're on a planning theme today. I want to just plug this particular planning piece. We have a CHAC work plan, and we currently have 3 big bucket items that we know we as a group want to focus our limited time and energy on. So we're approaching a time where we need to review that. We've done a little bit of review recently where I've gone over different objectives that we're working for and just asked generally if it still feels like something that we are wanting to invest our time and energy toward. But we need to do this in a more intentional way to make sure that we are coming away with a plan and action items for us as a group. And we want to have that work plan review and update completely done by June of 26. So I'm bringing this up now again just to plant the seed. There is a statute that we don't necessarily have reflected in our work plan. We talk about it, but we don't have it embedded in our work plan yet. So I think that's something that we'll need to talk through, and that is specific to prevention services in the county. So drug and alcohol prevention, mental health promotion, those types of services that are offered in the community, or that maybe we have gaps. I want us to think through what that looks like as far as actionable things that we can be working towards as a group by incorporating them into our work plan. So Alex, you might have to help me with some options that we were thinking of, because I'm going to get the time frames wrong. I think what would be really helpful for us to make sure that we get this done and not take up too much of our group time is to convene special meetings. So we meet every other month on our regular meetings. And so if we could pull together a strategic planning meeting in those in-between months, that's what would give us that capacity to be able to do that body of work, and then provide. Not everyone would necessarily have to be in those special meetings. You come as you are able, and then results of those meetings would then be shared out with the larger group in summary. Does that sound doable? I think there's an option for a retreat for the group to kind of kick off that process, or kick it off or summarize it. Either way. So do you all have thoughts on that? I'm getting notifications that my internet connection is unstable, so I apologize if I'm freezing or cutting out. Just give us a shout in the chat and somebody will see it in real time.
Would the special meetings be for staff and public, or just for?
So the special meetings will be public meetings, yes, and we would invite non-appointed members to have input to those processes. So yeah, that would include staff and members of the community who are interested in helping shape this body of work. Good question. Okay. We'll send out details on what that process might look like, and we welcome. It's not in stone. This is for us as a group. So if there's something that you think might work better, please don't hesitate to let us know. Okay. I think we're to our current work plan and taking a look at goal 2, which is, I don't know if we're able to pull that up for the group.
Yeah.
I'm digging through the ugly number of tabs that I have open right now. But Alex has us so organized with our,
I put it in order of how
Yeah.
hot we're talking.
yeah, just nailing it.
Only sometimes.
Okay, so goal number 2 is around health system coordination, and specifically that we as a group want to support our community in developing and implementing a sustainable network that formalizes health system coordination in Crook County. And what this looked like, or how this originally came about, was some folks talking about coordination meetings and work that have been really beneficial. So I believe that there was an example between St. Charles and Best Care. Angela, you might have to help jog my brain. But where there was regularly scheduled meetings between those entities to do case consults, to have again that time carved out, time and space carved out where we're talking about care plans and coordination of services with folks, whether they're frequent flyers in the emergency room or maybe they're not, and we just need awareness of how someone is doing so that we can all provide the best care possible. We identified that that worked, but that it's not necessarily happening with all of our providers and not necessarily consistently. Like if a staff person would turn over who was really carrying that charge, it would just stop happening. So we can see some of the tasks and listed under, what's that column? Oh, there's activities. So the activities around the care coordination meetings were to see what's currently happening, where any gaps are with providers, and then help support them in becoming sustainable. And then also having space to identify gaps so that, there's things that one person might notice, but they don't have a space to create system change. I think that's where our expertise is in this room, is how do we create a system change to meet a need. So I think that's the care coordination piece. And then we have a bucket around improving care transition between our behavioral health providers and our emergency room spaces. And back and forth. So from behavioral health to the emergency system. So I don't know if anyone would like to provide some observations on what's currently happening with that. This is a body of work that we haven't really dedicated a whole lot of our group capacity around, but I know that there's things happening. So if anyone has examples of things that are happening in the space that we can make note of, if there's any gaps that you guys see, or if this is something that we don't need to be working on anymore, we'll take those observations as well. So I'm going to give some space around, so again, care coordination meetings between behavioral health and primary care settings, and then improving care transition between behavioral health and emergency services.
Is there something up there? I can't see very well.
Oh, I'm
but,
sorry.
Oh, no, it's fine. I just can't see.
Go ahead and zoom in, so maybe
Let
we,
me zoom in.
yeah.
Well, I actually just reached out to Pacific Source to do care coordination. I don't know if that's relevant to this, but they have a case management care coordination too, for like a larger system look, for OHP clients. So
Mhm.
something to know, I suppose. We haven't connected yet, but
Yeah.
something that's available.
I think that's very applicable. If there's a resource that our providers don't know about that we can connect them with, or maybe that resource exists, but they're swamped, or, that could also be something that we could support. Is there anything else in this body of work that is either happening or not happening?
I don't know what other private practice therapists' experiences of like clients that go into the ER and come out. I know that's always a challenge. I always try really hard to reach out to whoever or whatnot, but I know the communication isn't always there. It's nice that, like Best Care and St. Charles are meeting, but I don't know about us like fringe therapists, but we still have people going to the ER and things like
Yeah.
that. So I don't know if there's a better forum for that or.
Angela, is your team still meeting regularly with St. Charles?
Yeah, so we've got a standing monthly meeting. Um, and the main focus for that meeting is crisis and our CET team, which is the ones who work with the high utilizers of the emergency department. Um, and then looking at like, what are some challenges that have come up and that kind of thing. We don't have any monthly staffings with like St. Charles Primary Care though, whereas we do have that monthly with Mosaic. And I know that that's been really helpful because, a lot of our clients do use Mosaic, but we have a lot of clients who also see primary care with St. Charles. But right now, that's that standing monthly meeting with St. Charles is focused more on the crisis and emergency department side of things and more of like brainstorming when problems come up. And I know was um was that Hope that was just speaking?
Yeah.
Brought that up. Because Hope, I know that like I mean I can think of something recently where like we had contact with somebody who was one of your clients. My people should have reached out to you, did they?
They did, but they didn't leave a voicemail. I'm guessing it was them. So that's what the counselors at the school said, that it was them that called me, but they didn't leave a voicemail.
Okay, because I mean, certainly we can, I mean, I can't tell you what St. Charles can do, but I can tell you that one of the things that we can do at Best Care is figure, I mean, I like we definitely sometimes in crisis see people and then we find out, oh, they're at Prineville Counseling or they're yours or they're somebody else's. And they should be making contact so that we can try and get that person, scheduled if they're not, or at least update the counselor. And so if that process, can be smoother on our end, then I can certainly work with our crisis services manager to figure out a smoother kind of way to do that.
Historically, they have, Angela. I've gotten calls, so, and, things happen and I'm always looking at ways I can coordinate better. I'm a care coordinator type social worker.
But
Erica,
now that St. Charles is utilizing the PAT team in the northern campuses, like previously it had just been like in Bend and a little bit of Redmond, and now they do have PAT team members, not all the time in the hospitals in the northern campuses, but certainly more frequently than they did. Then that means that we have less crisis response to the hospital, which is awesome for us because as mobile crisis, we should be going into the community more, not into the hospital. Um, but what that does mean is that there are often, like whereas before every single crisis call was us, and so then it could be us reaching out to these folks. Now I would say probably half the calls, or I mean half the crises that happen at the hospital are handled by St. Charles themselves. Um, and so that might just be a process for St. Charles to work out with. I mean, I would think that they would want to notify the counselor of a person that they're seeing. I mean, I would think they would, but we don't always get notified either when our clients are seen in crisis if we're not the ones responding. So, I mean, that's something that we've been bringing up. That's still sort of a work in progress. I think it's getting better.
for folks, Eric, I'm thinking of you specifically, but there might be others in this room who are serving folks not necessarily in the medical or behavioral health space, but Erica, your folks are in both of those spaces, right? The medical and behavioral health spaces. Is there something that are there any gaps or things that are working that you've noticed as a community provider?
We are meeting monthly with Best Care now. Their child and family team, their child team, and so that has helped tremendously, especially in regards to making sure our kids are getting to their appointments or we might have information that, their therapist doesn't know, family hasn't shared that or youth hasn't shared that, but it's something that's, super important to their treatment or vice versa. So I think opening that communication and we work closely with Hope. I know she's sitting in the room, but we staff with her, really and Rimrock, really, we've just tried to open up spaces where we can staff kids or combine kids, on a pretty regular basis because, prior, I would say that just like what's happening with primary care, kids they would miss appointments or they would be discharged from Best Care or they'd be discharged from wherever and we wouldn't know until, you know what I mean, until we're calling to make an appointment and it's like, oh yeah, that kid hasn't shown for the last, four appointments. And so we've discharged them. And so Angela and I had chatted and we created a space so that we could meet and have those discussions so that we can get ahead of it and kids aren't constantly in that in-between space. So we're kind of what our goal is here is kind of what we do now pretty regularly is have that conversation pretty regularly with our providers. I will say the emergency room situation for us is also difficult. And granted, we're not on the short list to make phone calls, but a lot of times because we are so involved in these youth's families and lives, and I don't know how to get on the short list, but so, it would be helpful when the therapist does know that this kid has been in crisis or has been, spent the weekend in the ED or wherever that case is, just opening up that communication because we're getting that sort of second and third hand and, we're trying to hold kids accountable and sometimes that needs to be put on the back burner if there's been some sort of crisis, but we don't know that until, that's communicated to us.
It sounds like maybe we could, oh, Courtney, go ahead.
This is, I don't know how related this is, but in my world, coming from ancillary outpatient care, I find a big gap for me to access mental health care for my outpatient population. Like we see kind of the whole gamut of people, but every time that we go to initiate a request within the system, within St. Charles system, we can send a message. Outside of the system, it's harder, but even getting like that follow-up care seems to be a big barrier.
And I would agree with that in the sense that if we do have a kid that has been in some sort of crisis care over the weekend or whatever, and they have a follow-up appointment, there's not really it seems as though there's not really someone following through with making sure that is happening or, you know what I mean, or following through that youth has an aftercare, like actually shows up for an aftercare appointment. And that's kind of when we find out that there's been a crisis situation. So, I would get Courtney in the sense that like there's a hole there, if that makes any sense. Like if somebody goes into St. Charles or we call crisis, there's a appointment scheduled to follow up. And if it's not with Best Care, usually if it's a Best Care crisis and the Best Care appointment, that's pretty smooth. But if it's a kid who's seen at St. Charles and they have been seen by the PAT team or whoever at St. Charles team, but their follow-up appointment should be with Best Care or their follow-up appointment should be with Hope, there's a hole there. Unless someone, like if we're made aware, then we can help coordinate that. We make sure, you know what I mean? But if there's not that middleman to sort of know to make sure that appointment happens, sometimes that's where the ball is dropped. I don't know if Angela would agree with that, but that's sort of where I feel like that ball is being dropped.
I'm sorry, I was being very rude and I was attending to an email that just came in and I heard my name and I did not hear what you asked me.
No, I was just saying
Sorry.
that. No, it's just when I talk, Angela, you know, just no, I was just saying that if it's Best Care crisis that sees a kid and that youth has best care therapist, that the ball isn't normally usually dropped in, right? Like you have a crisis situation and then you have a follow-up appointment. However, if a best care client is seen at St. Charles, a youth is seen at St. Charles for some sort of crisis, unless we're involved or unless we know, unless there's a middleman, sometimes that aftercare appointment is what's lacking. Or like if they're supposed to go see Hope, or if they're supposed to go see, somebody else. And I don't know how families navigate that who don't have a middleman, because that communication is lacking, going to what Courtney was just saying.
Yeah, I mean, I think it's getting better. But we're not always notified. And I mean, and let's face it, I mean, St. Charles is super busy, right? I mean, there's people coming in and out. I mean, I feel, for them. Um, but yes, I think that sometimes that happens, and then we find out that somebody was seen in crisis because we see it in Epic, not because we got notified and got something on the books. Or we find out at the person's next appointment and they come in and they tell us, as opposed to sort of that more proactive way of like, we'll get them seen that next day. So yeah, I mean, it's a work in progress. I do think it's getting better. Um, but it's still a work in progress.
Okay. Are there any other thoughts on this, the health system coordination body of work that we either need to be aware of that's working, or any gaps? All right. Well, thank you all for um, sharing how that's going, your experience with that piece. Okay, we have a couple things that we wanted to follow up about from our last meeting. I'm trying to remember how we were going to do that, Alex.
I think the behavioral health stuff was about the pilot project, and the transportation was just briefing them on the possible opportunity.
Okay.
Yeah.
So around the increased behavioral health trends that we identified or confirmed, you all identified, we just confirmed it with some data across the county that we are in fact seeing behavioral health concerns coming up more often in our primary care settings and our emergency room settings. And then and in addition to there just being more of it, it tends to be more acute. So one of the things that we've been exploring as part of our, we have a couple funding sources that could potentially be able to support this, but is having a platform that is available to everyone who lives in Kirk County would have access to this. And it has it has resources for the full spectrum of our mental health, right? It has you can do a self-assessment and it can tell you it seems like you're really doing well in this area. Here's some things you can do to keep that up. Or it'll ping that there are probably some self-help things that you could do. Here's some examples. Clear through like, hey, it would probably be good if you reached out to a care provider for this. Here are some local options. Clear through like that crisis space, right? And I'm not sure exactly what the crisis space in particular looks like. We've looked at a couple different platforms. And I think what we'd like to do as a next step, because we, as some of our staff have had have gone through demos of the programs and heard a little bit more detail, I think a next step could be sitting down with you all as providers to see if it would be helpful, if it would be at all compatible with your workflows. I think that's our next steps. And so we'll have staff reaching out to you all to give a bit of an overview of what the platform options look like, what resources they offer the community as well as us as providers. And I think that would get us ready for a larger community discussion of, is this something that we can sustain? So in both of these cases, there's an annual payment to sustain the platform.
And it would be
And
free to the community.
yeah, so the community would have access to them for free. It would be us as providers that would be making payments. At least initially, we have some funding that could get it started. I just hesitate to start something like this if we're just going to have to pull it in 2 years or 3 years even. So I would want us to have a plan for sustainability if it's something that we think would be really helpful. So look for emails from probably Alex, maybe Haley, and a couple other of our staff who would like to talk to you directly about what these might look like. And then we talked about medical transport and some gaps there, the expense of it. I know April talked about this from how Mosaic is experiencing it. And I know we just talked about transportation a bit, of like ensuring people are making their follow-up appointments and what resources may or may not be available to help make that happen. So we're also, similarly to the behavioral health screening platform, we're exploring some ideas for what could it look like locally to build our own system that works for us here, that could be an additional resource for medical transport. And so that'll be another conversation that our staff will reach out directly to you all as providers and service providers in the community to see if you think it would fly, if it would be used, if it would be sustainable, those kinds of things. Because we have got our own ideas about these things, but it's a big enough service that we would want to make sure that at least the majority of folks are on board with it and think that it would be helpful. So both of those things will have staff follow up with you all after this meeting. Is there anything else you guys have questions about in follow up to those two discussion items or requests that you have related to those? Alrighty. We might get out of here a little bit early. I think I'll leave some space if there's anything else for the good of the group. I know Alex has one, so
It's just for you.
for me. Okay.
Did you want to talk?
Oh yes. So on the agenda, it says that our next meeting is January 5th at 11:30. We'll send out location information for you all. We're approaching a time whereas we're planning out agenda items, we're having to bump stuff to future months. Like there are things that could have very well been on this agenda that we've pushed back. One thing that might help with that is if we made this a 2-hour meeting or, a longer meeting. And so I wanted to float that idea if that would be something, and we can send out a poll to appointed members. Yeah, especially since there aren't that many of us appointed folks here today, but I wanted to float it as a potential option because there are some things that we absolutely can't push out to other months, and then we're not necessarily being as responsive to the detox conversation came up there, and there's things that come up really at any time Alex sends out requests for agenda items. There's things that we have to kind of build out in future months. So please consider if a 2-hour meeting is something that you could handle, or if we need to change time or whatever to make that happen. I think that's a discussion that we'll have, and we'll send out a poll via email. So anything else for the good of the group?
I don't know if this is necessarily for the group. I mean, but it might be. I don't know if everybody is aware of the um sort of the CCO nightmare that is the reality right now. And Pacific Source being one of the CCOs that is making some pretty significant changes to a lot of things. They have laid off 300 people. And there have been pretty significant rate cuts across the board for a lot of places. We are in our contract negotiations with them right now. We don't anticipate that we'll experience rate cuts being the CMHP, but we certainly could. But I know that across the board, it sounds like most private practitioners and even some of the COAs have experienced pretty significant, up to about 30% rate cuts. And Pacific Source is also moving in a new direction of how they are contracting and paying. So for a very long time, it has been like the central or the tri-county area has been part of what's been called like the shared risk model, which has had a lot to do with performance payouts, with kind of like all of us working together with St. Charles and us and, all of that. And it sounds like they're doing away with that. And I'm not in those discussions, so I'm not as well versed to probably speak about it. But I guess I'm just sort of putting it on everybody's radar that there's gonna, Pacific Source is significantly down, I mean, 300 people is a ton of people to lay off, and they're making changes to how contracting is being done. So
I don't remember. Maybe somebody else in the room knows. Was that 300 people here specific to Central Oregon? Because I know Pacific Source in Lane County, they've pulled out of their
they pulled
Lane
out of
County
Lane
contract.
County.
Yeah.
I don't know if all 300 are from this area, but I know people who have been laid off. I mean, and
Yeah.
I think they have until the end of December. So certainly some of the people that I've been working with for years will no longer be in that position.
I wonder if we'll still have a care coordination person.
Question.
Yep.
How about heard her say anything?
Yeah.
She just left the meeting
Oh.
a bit ago.
All right. Anything else? Okay. Keep an eye out for emails from us. And as of right now, our January meeting is scheduled for the 5th. We might put an ask out similar to today. It's right around holidays. So we might put an ask out to make sure that that scheduled time will allow us to meet quorum. Otherwise, let's plan on the 5th, and we'll have emails out to decide on timing and whatnot if that needs to change. I appreciate you all coming. I know we're running from meeting to meeting, so thank you for running to this one, carving some time out of your day, and we will see you all in January, if not before.